Dr. Howard Stein is the medical director of the NICU at Ebage Children's Hospital and professor of pediatrics at University of Toledo College of Medicine and Life Sciences in Ohio.
In our neonatal intensive care unit, we are very aggressive about using non-invasive ventilation. All babies in the delivery room are given a trial of CPAP before they are intubated. We have found that even the smallest babies are, some of them are able to maintain on CPAP prior to requiring anything else. If they're failing CPAP, we will then institute some non-invasive ventilation, and in some babies, we've avoided intubation. With non-invasive ventilation combined with surfactant, either given by the Ensure method, where we put the endotracheal tube in, give surfactant, and take it out immediately, or ventilating briefly while we move from the delivery room to the NICU and then extubating, we found that going to non-invasive ventilation has decreased our reintubation rates significantly. It's also helped these babies a lot as they transition through from fetus to newborn with premature lung disease. We feel very strongly that all babies in our NICU who are on ventilators need to be on ventilators because they've failed a trial extubated and not because we've never tried. So if a baby is intubated and meets extubation criteria, irrespective of their gestational age or how immature they are, we will go ahead and give them a trial of extubation. If they don't do well and they need to go back on the ventilator, at least we know that this baby has to be on the vent. But if they can sustain on non-invasive ventilation, then we feel that that is significantly advantageous to the baby. In the NICU, our goal is to try and have our babies get through their neonatal course with as few long-term problems as possible. Our two major emphases are protecting the lungs and protecting the brain. Of course, the brain is really the one organ that has everlasting complications if we have any brain injury in the newborn period. But we also know that chronic lung disease contributes to poor developmental outcomes. So we have a strong dual focus between the two. In our micro-premature babies, we are very conscious of body positioning to protect blood flow to the brain. We want to keep the head and the body aligned. We also try and keep the head above the heart at all times so that the baby's never in the inverse Trendelenburg position. We work very hard on preventing chronic lung disease. We want our babies to be ventilated gently. We want them to have as much non-invasive ventilation as possible compared to invasive ventilation. And of course, once we can get them off all ventilation, that's very favorable as well. Between that and brain protection, our goal is to get the best outcome for the babies that we can. In our intensive care unit, the prevention of bronchopulmonary dysplasia starts right at birth. Our goal is to minimize as much invasive ventilation as we possibly can. Even during surfactant administration, we intubate, we give surfactant, and we extubate as fast as we possibly can to prevent any positive pressure ventilation using an endotracheal tube. Once we are non-invasive ventilation, we are aware that the interface we use, which is typically the RAM cannula, typically has a leak around 90%, so that we know that whatever pressure and volume the ventilator is delivering to the baby is far less that's actually getting to the lungs because of this massive air leak. So we are not concerned about how high the pressure goes non-invasively, as long as the baby is comfortable, his work of breathing is minimal, and his vital signs are stable. Our goal is to get that endotracheal tube out as rapidly as possible. And then once on non-invasive ventilation, our goal is to maintain lung recruitment. There's a lot of discussion in our intensive care unit about volutrauma, barotrauma, and biotrauma from the endotracheal tube being in the trachea. But we're also trying to emphasize atelectotrauma. And that's the trauma that happens to the lungs when the lungs collapse. So rapid extubation, rapid removal of non-invasive ventilation can result in microatelectasis progressing to macroatelectasis, and then the babies requiring reintubation to re-recruit their lungs. So as important as it is for us to get the endotracheal tube out, it's just as important, especially in the tiniest babies, to maintain a functional residual capacity so that these babies don't slip backwards from atelectasis. With that in mind, we try to maintain some sort of positive pressure until the babies are a little older and a little bigger. But what I mean by that is typically around 1,200 grams or even a little bigger in any particular baby, and somewhere around 31 to 32 weeks. We will keep them either on non-invasive ventilation, CPAP, or a high-flow nasal cannula. Once we feel that they have the ability to maintain their own lung recruitment safely, we will then wean them off all respiratory support. Our results have reflected that this seems to be an effective strategy. Our chronic lung disease rates over the last 10 years have steadily decreased, and we are now in the top 25th percentile of the Vermont-Oxford Network database, having relatively low chronic lung disease rates, and we've shown this consistently year after year. Our intubated times in the NICU are extremely brief. Any baby that's intubated is usually intubated less than about 36 hours. Of course, there are those babies that require going back on the endotracheal tube. They have invasive ventilation for prolonged periods of time, but they really are few and far between, and typically are the 22 and 23 weekers that we see this with. Our chronic lung disease rates also are very different from what they used to be as far as the type of chronic lung disease we see. Vermont-Oxford Network defines chronic lung disease as an oxygen need at 36 weeks corrected age. We used to see multiple babies that were intubated at 36 weeks corrected age, and those all have chronic lung disease. But we also had babies that were on a minuscule amount of oxygen, a quarter liter, 100%, getting ready to go home. And they also, by definition, have chronic lung disease. However, those are two very different babies. What we've seen over the last 10 years as our strategies have changed is that our intubated babies at 36 weeks, and then those who go on to need trachs, have decreased significantly. And when 10 years ago we used to see 3 to 5 babies a year requiring a trach, we now have about 1 baby every 2 years that has chronic lung disease significant enough to require a trach. It is very, very unusual for us to have a micro preterm who is still on mechanical ventilation invasively at 36 weeks. We have an occasional one who's on non-invasive ventilation at 36 weeks, and then a handful who's on high flow, and a few on a quarter liter nasal cannula as well. So our numbers over the last few years may not have decreased significantly, but the type of chronic lung disease, or BPD, that we see has really evolved into a much more benign type than the typical ventilated and trach requiring babies that we used to see. Our approach to managing term babies that require mechanical ventilation is very similar to the way we deal with preterm babies. That is, we provide them invasive ventilation as long as they need it, but rapidly try to move to non-invasive ventilation. The major types of babies we see are those with pulmonary hypertension, pneumonia, and then an assortment of congenital lung anomalies. The babies with congenital lung anomalies can be challenging, especially the diaphragmatic hernias. We have found that preoperatively, babies with diaphragmatic hernias respond very well to NAVA ventilation. Even though they only have one intact diaphragm, the neural signal is picked up at the level of the crural diaphragm, and babies with diaphragmatic hernia usually have an intact crural diaphragm on both sides of the spine, including the side with the diaphragmatic hernia. After repair of the diaphragmatic hernia, we have been able to ventilate them very successfully using NAVA in both those babies that were primary repaired as well as that those were patch repaired. There are a number of articles that have been published looking at these babies, and the literature seems to support that this is an effective way to ventilate these babies. Again, our goal is to get the endotracheal tube out as fast as we can. In babies with pulmonary hypertension from either pneumonia or meconium aspiration, we try and be very aggressive about preventing intubation. To do that, we use nitric oxide non-invasively, and that is really our first step when we suspect pulmonary hypertension, is to use nitric oxide soon, non-invasively, and aggressively. With this technique, we have managed to avoid intubating many of these babies. Once we need to intubate them, most of these babies get surfactant, not because they have immature lungs, but because we know that meconium, blood aspiration, and infection can all inactivate their surfactant. So we will give them surfactant to try and replace the inactivated surfactant until they're making new surfactant themselves. Once again, we work aggressively to try and extubate them. We also will use NAVA ventilation in these babies because they are able to pick lower pressures, lower volumes, and recruit lung when they need to, only for the periods that they need to recruit lung, and then they go back to ventilating at very low pressures again. This technique, again, has been very successful. Very few of our babies have had respiratory failure to the point where they need to go for ECMO from these sort of problems. Again, just looking at our numbers, 10 years ago, about 5 to 7 babies a year would be sent for ECMO, and currently we are only sending 1 to 2 babies a year off for ECMO, and probably only 1, and occasionally both of those babies will need ECMO. But it is very unusual for a baby in our NICU to require ECMO with our early aggressive management. We know that nutrition is essential to help these babies recover from their pulmonary insult in the term babies and to help them through their prematurity in our preterm babies. We, in the past, used to wait for significant respiratory stability and then respiratory improvement prior to starting feeds. But we now start feeds very early. Most of our babies, including the micro preterms at 23, 24 weeks, are started on feeds within 24 to 36 hours of life. And we follow a feeding protocol so that we have consistency from one provider to the other to try and advance the feeds on a steady basis to get them adequate calories. We are not just looking for any calories, but most importantly, we want protein calories to try and get our babies into an anabolic state to try and help with healing. The only times we hold off on feeds are those that have GI anomalies, obviously, and also those babies that are septic or have other reasons to have an ileus. We assess babies daily and sometimes twice a day to see if there's any feeding readiness. And as soon as we feel that it is safe, we will start instituting some sort of gut priming and then start advancing feeds as tolerated. We also start TPN on day of life 1 in our premature babies because we feel it's important to introduce not only glucose, but protein as well. By the second day, most of these babies are getting fat as well in the form of intralipid. Again, our goal is to get these babies anabolic as soon as possible so that they can start with maturation and healing to try and protect their lungs in the older babies on ventilation, and also to try and build muscle so we can get them off all types of ventilation in our preterm babies. Whenever a baby comes into our NICU, our thought is, how can we protect these lungs short-term and therefore long-term? Our goal is to provide as much ventilation as they need at that particular time. So the strategy we use typically is NAVA ventilation, because that allows the babies to pick how much ventilation they want on a breath-to-breath basis. This is really personalized ventilation, which means that when the babies are experiencing atelectasis, their CO2 starts to rise, their PO2 starts to fall, they need to recruit lung. And using NAVA ventilation, they are able to increase their respiratory drive as reflected by their electrical diaphragmatic activity. And therefore, they get big breaths, which we consider as sigh breaths or recruiting breaths, to then recruit the lung. Once they've recruited lung, they are then able in real time to drop back to just get the minimum amount of pressure they need to maintain ventilation. So then, rather adjusting the ventilator from blood gas to blood gas, we take advantage of the fact that the baby's brainstem monitors blood on a moment-to-moment basis and adjusts breath to breath to give the babies exactly what they need. We feel that this allows the babies to protect their lungs from excess overinflation from either pressure or volume. We have the Herring-Brewer reflex, which is protective for us. This is a negative feedback to the brain that turns off our respiratory effort when our lung reaches adequate inflation. Premature babies have demonstrated that they have a similar Herring-Brewer reflex that seems to be intact, it seems to be functional. And we take advantage of the fact that these babies then, using this negative feedback to their brainstem, will terminate their breaths prior to over-distending their lungs, and in this way will be lung protective as well. Our aggressive approach to taking out the endotracheal tube and moving to non-invasive ventilation provides a form of lung protection as well. We will then wean the non-invasive ventilation as rapidly as we can in order to get down to CPAP, and then less than that as soon as the babies are stable and we feel that this is safe to do. When we have babies on mechanical ventilation, both invasively and non-invasively, we have a dual strategy. The one thing we look at is oxygenation, and the other one is CO2 removal or ventilation. From an oxygenation standpoint, we typically use surfactant as our first line. Well, of course, our first line is actually giving some oxygen. But once we get over 30% oxygen, then our next line is giving surfactant to try and help with the oxygenation. Once we have addressed the oxygenation needs with increasing the FiO2, giving surfactant, we then look at it from a ventilation standpoint or a ventilator standpoint, and we will give the baby adequate PEEP to maintain functional residual capacity and keep the lung open. The second thing we look at is ventilation or CO2 removal. If the baby has CO2 retention and we feel the baby needs ventilation, we will move from CPAP rapidly to non-invasive NAVA. And we pick non-invasive NAVA because of increased synchrony that occurs between the patient and the ventilator. We want the baby to synchronize for initiation of the breath. We'd also want them to synchronize for the size of the breath and termination. So the flow trigger is not an effective trigger with non-invasive ventilation. The leak is too big, and there's a lot of mistriggering. There's a loss of false triggering, early triggering, late triggering, and ineffective triggering. With the neural trigger, it is leak independent. So this gives us an opportunity to synchronize, and it is the only way to synchronize with non-invasive ventilation. Invasively, again, once we've dealt with the oxygenation issues, we will use invasive ventilation to bring down the CO2. Once the CO2 is under control, we have these babies on invasive NAVA so that they can auto-wean. In other words, as they're recruiting lung and blowing off CO2, they will have high pressures, high tidal volumes, and high respiratory rates. As their blood gases normalize, they auto-wean their own respiratory rate, they auto-wean their own pressures. And what we start to do is cut back on the NAVA level. Now, the NAVA level is a distribution of the work of breathing between the baby, the biologic diaphragm, and the ventilator, which we view as the mechanical diaphragm. A high NAVA level means that most of the work of breathing is coming from the mechanical diaphragm, whereas a low NAVA level means that most of the work of breathing is coming from the biologic diaphragm. In the beginning, we start them on a higher NAVA level because they have respiratory failure, and we want the ventilator to pick up most of the work. Once the baby's lungs start to improve and they are able to take on most of the work of breathing, we will rapidly wean the NAVA level until they're at a NAVA level of 1. And at that point, if the FiO2 is less than 30% and the NAVA level is 1, we will go ahead and extubate to non-invasive NAVA and then resume the process again. Start at a higher NAVA level to unload work of breathing from the patient to the ventilator. And then as the baby is able to assume more work of breathing, we will keep lowering the NAVA level until we are able to wean off non-invasive NAVA and onto CPAP. One of the challenges of ventilation, both invasively and non-invasively, is patient comfort. And patient comfort appears to be related to synchrony. The flow trigger is synchronous for only initiation of the breath, but the rest of the breath, including size, volume, termination, all comes from the ventilator itself. Patients on flow-triggered ventilation are therefore relatively uncomfortable, and many of them will end up fighting the ventilator. In order to ventilate them effectively, many of these patients require sedation. The problem with sedation is you knock out their ability to breathe so that they develop lung atrophy, and at that point they become ventilator dependent, so that when you try to wean them off the ventilator, many of them will ride the ventilator, and it takes quite some time before their diaphragm becomes functional again for them to resume spontaneous ventilation without assistance of the ventilator. Using NAVA ventilation, you have far better synchrony, and the patients appear to be very comfortable. As a result, we use very little sedation in the NICU. And in fact, our only use of opiates is really for pain control in those patients that are post-operative or have other reasons, for example, a chest tube, to have pain. We use very little sedation because we want our babies to breathe spontaneously. We want them to breathe in synchrony with the ventilator. And we find that very few of them require sedation so that their weaning goes along much faster because their sedation needs are much lower. When COVID arrived in the United States, we were very unprepared in the NICU because we had not encountered a pandemic like this before. So the first few months were really spent putting together protocols and trying to find the best available evidence to deal with the babies. We had no idea what the transmission was from mom to baby, what the transmission was from baby to caregivers. So we presumed the worst and really used as much protective equipment as we could and try to keep everybody apart. With COVID, we kept the same principle in place, but we changed how we did it. We started using virtual meetings. We dialed into a common number, and we made an effort to make sure that the neonatologists never saw each other, so that if any one of us got sick, we would try hard to avoid giving COVID to anybody else in the group. Everybody wore masks, everybody wore gowns and gloves when we went to see babies that had COVID. We wore protective eyewear, and we were very, very cautious about what to do. In the beginning, we isolated moms from their babies. We isolated moms from us in the NICU. We restricted visitation. Over time, as more data has come out and shown that there is very little transmission from mom to fetus and mom to newborn, all these things have changed. We now allow moms and babies to remain together after delivery. If a baby needs to come into the NICU, we test them when they come in. They stay in isolation until we get 2 negative COVID tests, and then they come out of isolation. As soon as mom is considered not contagious by her physician, she is allowed to come into the NICU. Our visitation is still restricted to parents only or to mom and a support person, and we have not let extended visitors in. However, what we have done is instituted cameras in the NICU so that every baby has their own personal camera above the bed, and the parents can link in through an app on their phones, and they can see their babies. Not only are the parents able to do this, but they can share the code to see their babies with any family member or friend that they choose to anywhere in the world. At this point, I would say that COVID is inconvenient in the NICU. We are still all wearing masks. We are still staying away from each other as much as possible. But I think the risk to the babies from mom, to us from the babies, and most likely to the babies from any of us is actually very, very little. At this point, we've all been vaccinated as well, so that has increased the safety profile in the NICU considerably. So we've been very successful in weaning babies off invasive ventilation rapidly to non-invasive ventilation, and then relatively rapidly from non-invasive ventilation to CPAP, and then to high-flow nasal cannula. However, in the small babies, especially the 23 and 24 and 25 weekers, our biggest challenge has been apnea of prematurity. Even though these babies are on CPAP, they maintain ventilation excellently when they breathe. But when they have apnea of prematurity, then all they're getting is CPAP, and that is insufficient to support them. So many of them will have significant desaturations and bradycardia and require escalation of care. We are very aggressive with our caffeine use, and all our babies are routinely on caffeine. However, that is not sufficient in many of these babies. So our goal really conceptually is to provide CPAP when these babies breathe, but when they have apnea of prematurity, we would like to provide them with non-invasive ventilation. So our options have been somewhat limited. We could put them on NIV pressure support. What that will do is deliver pressure support every time they take a breath. But when they go into apnea, then what happens is they should get backup ventilation from the ventilator. Unfortunately, the flow trigger is not very sensitive with non-invasive ventilation. So often they will get extra breaths when they are breathing, and they will get asynchronous ventilatory assist when they're breathing. And when they become apneic, it is not unusual that the ventilator doesn't detect the lack of a flow trigger because of false triggering and doesn't deliver any breaths, or delivers breaths inadequately for these babies during apnea or prematurity. So they get overventilated somewhat or over-assisted somewhat when they're breathing and insufficiently assisted when they're apneic. Our next option is to go to NIPPV, or non-invasive ventilation with pressure control. And that means that they get a pressure control breath every time they breathe. They get assisted significantly. And when they don't breathe, they continue to get that big pressure control breath at the predetermined rate that you've set. The challenge is the same as we saw with non-invasive ventilation with pressure support. They get too much support when they're breathing because they don't need it. They only need CPAP when they're breathing. And then they get sometimes inadequate support when they apneic, or they get adequate support when apneic, but way too much support when breathing. Also with non-invasive pressure control, we've noticed that the babies will sometimes flip into an auto-trigger mode where the ventilator is auto-triggering from water in the tube or for some other reason, and delivers way too many breaths to these babies, can actually hyperventilate them and make apnea or prematurity worse. Our third option then is to give non-invasive NAVA. Non-invasive NAVA is effective because when the babies breathe, they get support from the ventilator, but when they don't breathe, they get backup non-invasive ventilation with pressure control ventilation. The disadvantage is when they breathe, all they require is CPAP. They don't need NIV-NAVA from the ventilator. They don't need that sort of support. But when they apneic, they're getting the ideal support. So our approach then is to drop the NAVA level down to 0. That means when they breathe, they get a NAVA level of 0. So they get a pressure of nothing above their PEEP level. Actually, what the ventilator does is it really delivers about 2 centimeters of water above PEEP, but that really is minimal compared to getting a positive pressure breath. So what happens then is effectively when the baby is breathing, they receive CPAP, exactly what we were looking for to start with. And then when the baby becomes apneic, they go into backup ventilation. So we feel that using NIV-NAVA of 0 is truly delivering CPAP with backup ventilation. If you are uncomfortable with the fact that the baby gets a pressure of 2, which with each spontaneous breath they get, then what you can do is just drop your PEEP level by 1 or 2 from what you wanted to give. So if you wanted this baby on a PEEP level of 6, drop it down to 5 or to 4 so that their mean airway pressure becomes 5 or 6 if they're getting that little extra 2 with each breath they take. And then, of course, their mean airway pressure will be significantly higher when they're apneic because they'll be getting pressure control ventilation. So using this technique, we have found that it has been very effective in our 24 to 26 weekers to keep these babies off non-invasive ventilation and off invasive ventilation. And actually, we've been able to maintain them with minimal respiratory support. In other words, CPAP when they breathe spontaneously and backup ventilation when they have apnea or prematurity.